Welcome to Porchlight, a presentation of Porchlight VNA and home care, providing top-rate, highly personalized and compassionate care to individuals and families in the Berkshires and also in the hill towns of Hampden and Hampshire counties, all in the comfort of their own home. And the healthcare world is very complex, but when it comes to end-of-life care, the paperwork and all the details can even be more complex. And that's why I'm very happy to welcome to the program a nurse practitioner for Porchlight VNA and home care. She is Barb Tracy, who just recently did a presentation on specifically the new MOLST form, which is probably becoming the predominant form being used for end-of-life care among many other tools that people have. So Barb, it's a great pleasure to have you on the program.
Thank you for having me.
And this is such a great service to provide to the community because, you know, as I said in the intro, healthcare can be complex enough, but then when you get toward the end of life and you have family members who are involved and caring and of course want the best for their loved one, it can get very complex with things like living wills, like DNR orders, and all these different things. It's a lot for families to deal with.
It really is, and the dialogue at end of life really needs to take place. And I think it's really our obligation as healthcare providers to address that in a really compassionate way with family members, more in a way emotionally and spiritually, not just saying, do you want a breathing tube, do you want these treatments, but we really need to encompass the entire spectrum of end of life. Part of that has to do with addressing what a person needs and wants at end of life, because at the end of life, a person can choose to have a breathing tube, can choose IV hydration, dialysis, a number of things really to prolong their life or to have comfort measures. So the MOLST form is a form that's being used more and more in Massachusetts and many other states. And what we're doing is educating the public right now and educate medical professionals as to the importance of the form and how to fill it out. Did you want me to explain the MOLST right now?
I mean, I think the important element is, first of all, yeah, healthcare professionals need to know about it.
Right.
And then, of course, family members, you know, typically are going to follow the lead of those healthcare professionals, you know, on those recommendations. So, you know, perhaps we can talk a little bit about how the MOLST form is different than, for instance, I mean, a lot of people know the term DNR. That's the do not resuscitate. That's an order. And how is that different? How is a living will perhaps different than the MOLST form? Because this seems to be the new form that predominantly will probably maybe take over a lot of these, you know, this aspect.
Right. This is much more specific. A living will is a written documentation of a person's preferences, what they would like at end of life. But a living will is not legally binding in Massachusetts. It basically tells providers what the person wants. I don't want this, I do want this, but it is not legally binding. A healthcare proxy is basically naming someone legally to speak for you when you're incapacitated. So that's the difference between those two. A DNR is an order for do not resuscitate. So that is an actual order. If you come into the emergency room and you have a do not resuscitate, then people can honor that. A MOLST, on the other hand, is much more specific. A patient has the ability to sit down with a healthcare provider and decide not only will I be ventilated, will I have someone breathe for me, will I receive CPR compressions in order for my heart to continue going, but also hydration, dialysis, maybe intermittent ventilation. They can choose a lot of different modalities where with a DNR, it's only do not resuscitate, do not intubate. This is much more specific, and it also can be time limited. So they actually have a lot more say in this, and this is an actual order. where a living will is just their preference, and a healthcare proxy is just someone who says, but Dad doesn't want this, and Dad doesn't want that. This is actually what Dad said, and is an order. It's a medical order. And EMTs follow the order, and this is across all patient care settings, in the hospital, in the home, if they're at the golf course and they have this with them. With the MOLST, the patient has the original copy, the pink, and copies of it are valid. So copies will be put into the healthcare record, the electronic healthcare record, and copies can be made to be given to other family members to have, and they are valid. The copies are valid. So these are really important to keep with the patient in their home, and to have other people keep it, and to have in the medical chart.
Right, so there's a clear understanding that everyone is literally on the same page on this kind of thing, because they're really important decisions, because you see many times toward the end of life where there is confusion.
Absolutely.
And then family members are, perhaps at odds, depending on what to do in the case that mom or dad is in that particular, life-threatening situation.
Exactly.
Do they stay on a ventilator? Do they, do we continue with this kind of care? Now, for this specifically, what would make someone eligible to have a form like this? Because it's not just for anyone. It's for people with, I guess, life-threatening or life-shortening types of
exactly. Someone with a terminal illness.
Terminal illness
is eligible for this. Someone who has a life-threatening illness. Someone who's extremely frail. It's not just for anyone. Where a DNR it's a little bit looser, but this here is for someone with a life-threatening illness. It's a portable document for those people, but it's very specific for someone really with really an end-stage illness, end-stage CHF, end-stage renal disease, when they've decided they don't want any more. Okay, so it's very, very specific. The difference between the MOLST and the healthcare proxy, for instance, is the healthcare proxy is a legal document, where the MOLST is a medical document. For the form users, patients of any age with an advanced illness, it has to be an advanced illness, can have this. And with a healthcare proxy, all adults 18 or older can have a healthcare proxy. Okay. The form on a MOLST, it has current medical orders about life-sustaining treatments, and the healthcare proxy, it's the name of the healthcare proxy. The form signers for a MOLST would be the patient and either the physician, nurse practitioner, or a PA. With the healthcare proxy, it's the patient and 2 witnesses. But again, this is much more all-encompassing, and it's much more, leaves no questions. It really doesn't.
And speaking about the presentation that you gave recently to healthcare professionals in the Berkshires and beyond, actually, I think there's some people outside Berkshire County who also went to it. Tell me about the questions that were coming up, because again, it's not just families who may be confused about this. Again, in healthcare and just like a lot of industries, there's a lot of regulations, and you know that as well as anyone. So, what are some of the questions and or concerns that sort of arose during your presentation from healthcare professionals?
One of the questions was if the MOLST is accepted across state lines. And actually right now, the answer most people are saying is yes, but it's still muddy. I know in New Jersey they're using it.
Because on the top of it says Massachusetts medical orders.
Right. But many states are adopting this. The consensus is now that yes, it would be accepted, but that's still pretty muddied. And that's in the works to be worked out. But for the most part, this seems pretty clear to most healthcare providers that this is really cut and dried and is a lot clearer than anything we've ever had before. Because a lot of times we'll get people into an ER with family members saying, but we have a living will, and this is what he wanted, but then you'll have another family member who says, but wait a minute, he changed his mind.
Right, exactly.
And another thing, with a MOLST, a family member who fills out a MOLST, a patient, can change their mind. In 6 months, they could say, you know, I'm really feeling better. I really want this changed. So you can immediately avoid this MOLST and change it to what the patient wants. So it's never set in stone. They certainly can change this at any point. And then this is destroyed and a new MOLST is done for them according to whatever wishes they have.
That's a good thing, because I mean, like we've seen, you know, whether, you know, even patients who are on hospice, they can improve,
right,
and then leave hospice care and have a different level of care. Now, you know, looking at all this, I mean, you are on the forefront of this because you're passionate about this.
Oh, absolutely.
Because you have had your own personal experiences as a professional, you know, in these cases, and certainly that clarification is so important because you know, there are these rules, written or unwritten, in healthcare, you know, that you need to follow, and part of that is being compassionate and being able to care for people properly, even at the end of their life, and also recognizing the life cycle that, you know, sometimes a certain level of care is appropriate for someone at a certain age, where it's far different than someone at a different age. So, and that's something that healthcare professionals, they have to understand, you know, to provide compassionate care.
Correct. And I find that medical education really needs to put more emphasis on that, because it is very difficult to address end-of-life care with anyone, if they're 96 or if they're 26. And I really think that we in America have a really difficult time handling that and dialoguing with a family about end of life, because we want to make things better. We don't want to have to deal with the end. And it is a very emotional conversation. And a lot of times we have to kind of pull back and look into ourselves and deal with it ourselves first before we can actually take care of our patients. I really think that's important. So an important aspect of all of this is nursing education and medical education. We really have to address that. I can't stress that enough, because just recently I came across a situation where a young medical resident really had a tough time understanding a situation in which an elderly woman and family really needed time just to talk about, maybe we don't need to do any more medical interventions, and instead went right to the numbers rather than looking at the patient in the bed and the family standing around the room and saying, maybe we need to talk about the plan. And it was the compassionate aspect that should have been talked about, not the oxygen saturation dropping.
Right.
So the compassion aspect was missing. And it wasn't this person's fault. I think we, in this country, we really need to focus on more compassionate medical and nursing education on dealing with end of life. It is an absolute travesty if we don't do that.
And you raise a great point, because again, we're talking about people, you know, and you always hear the buzz word patient-centered care, and that's, you know, kind of one of the things you hear in healthcare quite a bit. Well, you have to live it, you know, you have to be it, if you know, and that means understanding, you know, human beings more than, like you said, just the numbers on a screen and that sort of thing. So, you know, in your role at Porchlight VNA and Home Care, you are a nurse practitioner, which is a very high clinical level, and that's important to have that clinical strength for an organization. You know, Porchlight is a 100-year history, originally Lee VNA and Lee Regional VNA. You know, from your perspective, how important is it for a VNA to have that nurse practitioner role as a hands-on role with the organization? It's
really important, because we do a lot of teaching, particularly with people who, for instance, if they're discharged from the hospital and they have CHF, or some disease that really needs a lot of intervention to prevent them from going back into the hospital, and there is a very high rate of anyone with CHF going back to the hospital. So there's really a lot of teaching about patients' lifestyle, their medications, the foods they eat, and to me, as a nurse practitioner, to be able to go in to meet that person in their own environment, it's so much easier for them to be comfortable, to hear what I have to say to them, and to just meet them in their own space. And it makes them more relaxed and able to hear what I teach them, and find that they follow through more easily. I usually make follow-ups to make sure they understood what we had talked about from our first visit, and I find people do much better when they're taught in their own home. They're just in their own space, and they own it, and they feel empowered. And once they have that information, and we share that information, and even just sharing a recipe with someone something that's good that they're able to eat on whatever diets they're put on, really makes them feel happy and empowered. And they enjoy these visits. And just by these simple little visits we think are simple, to them it really makes them feel so much better, and I see them improve. You see their vital signs improve, and you really see a decrease in them going back into the hospital. I think that's major.
And as far as the model, and I think, and of course, with healthcare reform, we know that readmissions are so important to reduce those, and that means great outcomes. Porchlight, statistically, all over the board, excellent, as far as patient and clinical outcomes, and as you suggested, having people able to be educated within their own homes, and be able to have that experience in their own homes. There's a comfort level, but also it almost as if it sort of harkens back a little bit to house call days, and so that everything for so long had been facility based, nursing homes, hospitals, all these things, but like you said, you don't feel any more comfortable anywhere else than you do in your home, and to be able to bring a high level of care there, which from all we're hearing with healthcare reform is the way that we want it, because we don't want readmissions to the hospitals because it gets more and more expensive for the system. So it seems like going back to the old school, but in reality it just makes a lot of sense.
It really does, because we're taking our knowledge and just bringing it into the home. And many elders find it very taxing to even go to an office visit. It tires them out. And they can't find people to give them a ride because their daughters or sons are working. So it's so much more convenient for us to go to their home, and it really just makes it better for them all around. And having the energy to hear us, to listen, and to follow the instructions that we provide them at home. It really makes a huge difference. And having also technology that enables Porchlight to be able to follow and make sure monitor all this.
The telemonitoring system, which is so important, and that makes the whole thing more efficient.
Absolutely.
And of course, people not having to wait in waiting rooms and that sort of thing. It just makes a lot of sense, and especially as we're talking about people who may be having illnesses that are bringing them toward the end of life as well, that comfort level where you want the quality of their time to be focused on family and doing what they want, not, for instance, waiting in waiting rooms.
Exactly.
And also having family be so involved in their time being put into the care for a loved one. So again, enhancing the quality of life.
And our whole team, with the nurses, physical therapists, occupational therapists, just the whole team provides almost a family-like atmosphere to the patients. And there's a bonding that happens that patients love. They really love it. And to me, that compassion makes all the difference in the world. It really does. And I've seen it. And I've seen people heal from the compassion. Knowledge combined with compassion, with this whole team of caring people, you can only equal one thing. And I see people truly heal every day.
Yeah,
From-
and a positive outlook makes a big difference.
yes.
I don't care what anybody says.
Absolutely.
And you know that as a medical professional. So as we have a few minutes left, Barb, tell me a little bit about your career and how, first of all, you got into healthcare in the beginning, and now as a nurse practitioner. How does one become a nurse practitioner, for instance?
Well, I started out as an art major and went into psychiatry and loved that very much. Went into nursing and did psychiatry at Austin Riggs for many years. Then worked at Berkshire Medical Center in Fairview Hospital for many years and loved that very much. And then finally became a nurse practitioner 2 years ago. Because I just wanted to expand my knowledge base and really loved hospice. I did hospice nursing for 8 years and absolutely loved it. So, and that was home care. So my passion really is hospice and palliative care, but I can really take care of the family as a family nurse practitioner doing house calls. And I really am, that's where my passion is now, is with Porchlight, doing house calls. But I also do primary care at East Mountain Medical, which I'm still allowed to do that whole compassionate care there. So I really have kind of come full circle where I can be really creative, think outside of the box, be compassionate, spiritual, and just really take care of the patient and the family. And it just is very satisfying to me to be able to do that. And being at Porchlight really gives me that opportunity.
And I think that's interesting because your background is so different. You know, you have that diversity, and I think it fits right in perfectly with Porchlight. That again is personalized, which is
absolutely.
about that human element that makes that really makes it different than your traditional home care or what have you. And
Right.
there are other agencies who do great jobs as well, but there's something special about Porchlight, and I've been in healthcare for a while here in Berkshire County, and I truly respect the work that they do. It is truly excellent and high level, and your work certainly reflects that. So as far as your expertise on the MOLST form, people I'm sure can get in touch with you. So how should people learn more and get in touch with you to learn more about the MOLST form?
They can do one of two things. They can call Porchlight, and I'd certainly be happy to talk with people about MOLST. And also they can go on to a website, and this is on the internet. It's www.MOLST, M-O-L-S-T,
dash hyphen,
ma.org.
So there you have it. So it's MOLST-ma.org.
Right, and it has a section for clinicians and it has a section for families and patients, and it's really all-encompassing. It has facts. It's really a wonderful site.
Fantastic. Well, Barb Tracy, nurse practitioner for Porchlight VNA and Home Care. It's a great pleasure to have you on the program.
Thank you for having me.
And you're really a wealth of knowledge, and you're doing some great work.
Thanks.
So thank you for coming on the program. And this has been Porchlight, a presentation of Porchlight VNA and Home Care. Thanks for watching.